We are. Yeah. Good evening, ladies and gentlemen. Welcome to Luton Health and Wellbeing Board this evening. I shall be chairing this evening, Dr. Nina Pearson, as Hazel Simmons is not able to attend this evening. If I can just remind members, am I echoing? I think I'm echoing. Is that the volume or is it me? Is it? Yeah.
We had that problem, but I think it's okay.
So the meeting this evening will be live streamed to the public. The recording of the public part of the meeting will be available on the council's website within 24 hours of the meeting. Members and officers, please remember to switch the microphone on when you're speaking and off when you've finished, and speak directly into the microphone. We've got remote participants joining by Teams, so please raise your hand with the hands up button to indicate you have a question or a comment. And those joining by Teams, please turn your cameras on when speaking and off when finished. And for people attending, please switch off your mobile phones or place them on the silent mode, which I will duly do myself. Thank you. So if we look at the proceedings for this evening, first of all, do we have any other apologies for absence, please, Bert?
Yes, Chair, we have apologies from Councillor Simmons, from Robin Porter, Anita Pisani, Lucy Nicholson, and I think that's about it, Chair.
Thank you very much. Any others to note? Yes. And Felicity Cox, thank you. And Kathy Nelson. Yeah.
Chair, we've also got apologies from Councillor Underwood, who's an observer.
Thank you. So we will note those apologies. Thank you very much. So if we look at the minutes of the last meeting, which was the 17th of October, could I ask colleagues, are they a correct representation of the meeting? Are there any points that you would like to raise on the minutes of the last meeting? Not seeing any hands going up online or in the room, so I will take it they're an accurate record. I did read them earlier today and I thought they were an accurate record, so I will sign those minutes before leaving tonight. Thank you. Any disclosures of interest? No, thank you. And any urgent business?
None, Chair.
Thank you very much. And any references from committees or bodies?
None, Chair.
Thank you very much then. Okay, so we'll move to the first report for the meeting, which is item 6, application to consolidate 2 pharmacies owned by Lloyd's Pharmacy. So presenter is Jade. So is Jade in the room or online?
Online, thank you, Chair.
Right, thank you. Over to you then, Jade. Can you take it that we've read the report? So if you bring out the highlights for us, please.
Yeah, perfect. Thanks, Chair. Yeah, so I'm Jade Horsley, Public Health Manager. So the purpose of bringing this report to the Health and Wellbeing Board is just to inform you all of an application which NHS England has received to consolidate 2 pharmacies that are owned by Lloyd's Pharmacy Limited and provide you with the opportunity to comment. So the first site, Site 1, is located in Marsh Farm Shopping Centre. And the second site is located in Brammingham Park, Sainsbury's. The sites are 23 minutes walking distance from each other, and the proposal is to close Site 2, Brammingham Park, Sainsbury's. It has been considered that a gap in the service is not anticipated due to a number of reasons. The 2 pharmacies are in close proximity of each other and are accessed by similar patient groups. Site 2 is quiet in terms of pharmaceutical services and retail sales due to low patient footfall. The area is not being left without a pharmacy, so they will have access still to services. And it is anticipated that there'll be no interruption to services. However, in consolidating the 2 sites, the remaining site, Site 1, would lose access to toilets for wheelchair users and the translator service. In terms of the information which we've received, the two sites have different operating hours. So site 1 is open till 5:30 p.m. Monday to Friday, but closed weekends, and site 2 is open until 10:30 p.m. weekdays and also open on weekends. So the deadline for the Health and Wellbeing Board to respond to this is the 23rd of February. So an ask from you all is just to consider the report in full and provide any comments to me, so then I can collate a response back to NHS England on this.
Thank you, Jade. So that's concise and clear. I have a question to kick off with, please. So on Appendix D, we're given a sheet that tells us the opening hours. So section 3.1 is current core opening hours and current total opening hours. And then we've got site 2 at 3.3, it says core opening hours and total opening hours. And I didn't quite understand that, what the difference was between core and total, and also being clear about what the future offer is. Can you be clear with us what the future offer is if we agree, if site 1 only goes ahead, please?
Yeah, thank you, Chair. So this is just the information that we have been provided. So that is something that we will need to flag with them in terms of the hours, because obviously it doesn't actually state if site 1 is remaining open. Does that mean those hours are going to continue? Because obviously if they're keeping the same hours, then we could argue there's going to be a loss of service at weekends when people are likely to try and access that. So that's something we can take away and highlight to NHS England and see if we can get clarity on that.
Okay, thank you. Anyone else with questions from the room? Yes, Javid.
Thank you, Chair. So I'm not sure the definition of 23 minutes is a short one for somebody vulnerable. I'd have concerns about that, because 23 minutes walking for somebody who's frail and elderly is quite substantive. But then having said that, yeah, I'm looking at the Appendix A. One of the others might be a bit closer. It'd be nice if we can have from the one that's been closed, if we can see what the nearest one is, like in terms of mileage rather than postcodes. So is it 1.2 miles? Is it 0.5? I think that'd be better than postcodes. That would be. And the second, the biggest one for me is, even to consider that, yeah, they've got to do something with DA. This day and age, yeah, 2010, it's got to be wheelchair accessible. Even if there's a temporary, they've got to find a temporary ramp that they can bring for that user. But without that is absolutely a no-no. Without that, it's got to be even if it's a temporary solution, but it's got to have a solution for wheelchair users.
Thank you. I think that's a really pertinent point. As you say, it's important that it's accessible for all the population. So wheelchair access is one aspect of that. And I was concerned about the loss of translation facilities, because I think we could make that a requirement, that there is the ability to have translation facilities wherever it's hosted from, given the diverse nature of our population. So I think that would be really important. And I guess the other bit which wasn't very clear to me is the space sufficient for the pharmacy to do all the work we would like community pharmacies to be able to do, like the minor illness consulting service, like healthy living pharmacies, etc., etc. So it wasn't completely clear to me that it would be able to deliver the needs that we have for our population. And so I would want NHS England to address that. So any other comments from colleagues? Are we just about commenting? We can't say yes or no.
Yeah, just comments. So then I can collate them all, send them back to NHS England. So they'll obviously have that as part when they consider the application and the proposal.
Thank you. So got another comment, Jared?
No, I just to reinforce what you said. It's a very pertinent point about the translation. It doesn't need to be there on situ. You can have somebody at the end of a conference or something, yeah, because if somebody does need it, this day and age, it would be, I think, They don't have to have somebody there, but as and when they need it, call a friend or something. You know, I think that's very pertinent, especially as we've got such a diverse population in Luton.
And I'm not quite sure how that is provided currently in community pharmacies. In general practice, we have language line that is commissioned for us, and 90% of the time we can find someone with the right language skills, not always. And it is a phone up. So, you know, that is something that perhaps we do need. If it's not available to all community pharmacies, perhaps it should be, because if we're doing, minor illness consultations, you know, ability to communicate is really important.
And just a couple of really quick points, actually. One, when you looked at the report, I was hoping to see something around footfall mapping, so capacity. So once you close one, what does that actually mean by way of sort of like an impact to local people? And two, I'm not sure if it's in the context of the report, so apologies if that isn't the case. But actually, what's going to happen to the other site? So is this just about reducing costs and overheads? So I was just interested, really.
Yeah, thanks, Mark. So it's not clear in terms of the reasoning behind closing the pharmacy. And obviously all the detail that I've included in the report is what we've been provided by NHS England. So I would presume that's all they've received. So we can go back to them and try and get clarity on any of these sort of areas.
Thank you. Any other comments or questions? No, that's been very helpful. Thank you, Jade, and thank you for bringing that to us. Will we get notified? How will we get notified of the outcome?
So I'll collate a response back to NHS England, and then they should come back to us in terms of as the proposal progresses.
Thank you. So, it will be collated by the, yeah, thank you, and let us know. Okay, thank you. Let us move on now then to item 7, which is the Luton Tobacco Control Strategy, which I think, Rafiq, you are to present, is that right? And again, take as read that we've read the report.
Could you use either end, please?
Either end?
Yeah.
No.
Thank you.
Thank you, Chair. Nusrat, could I get the slide, please? Thank you. Excellent. Thank you very much for this opportunity to update the Health and Wellbeing Board on the Luton Tobacco Control Strategy. Apologies from Serena Abel, who's been leading on this work. Unfortunately, she's unwell, but I know she would have loved to have been here, as she's really driven it forward over the last few months. But myself, Suleiman Rafiq, Public Health Principal, and my colleague,
Jerry Reeve, Public Health Development Officer.
great, are here just to take you through a 10-minute presentation to bring out some of the highlights from the report that you've received, and then we're happy to answer any questions. Can I have the next slide, please, Nusrat? Thank you. So actually, every time I look at this this specific graph, I always notice something different. So the first thing I noticed when I looked at this graph, that when my mum was born, half of the UK's population smoked. And actually, within quite a short period of time, because my mum is very young, you can see now the progress that's been made in relation to the tobacco control agenda. But what's really clear on this is that smoking rates don't come down on their own. They require consistent and informed and evidence-based action. And we're quite fortunate in this country that we've made the progress that we have. But the second thing that I notice when I look at this graph is actually we're at a stage now where we have to see this through to the end. And actually, what the Luton Tobacco Control Strategy outlines is a clear roadmap to getting the prevalence down in Luton so that we can finally eradicate smoking and smoking harms from our community. Can I have the next slide, please, Nusrat? So let's look at that, what that means at a local level. So you can see here, over the last 10 years, not consistently, but rather erratically, smoking rates have ultimately come down. And, you know, that's been a real joint effort across the town, working in partnership with a range of different partners. But what we'd really love to see here from a public health perspective is a more consistent downturn. And we feel that in order to achieve that, we need to really focus on and consolidate the tobacco strategy, working with our partners through the Tobacco-Free Luton Partnership. Next slide, please. So I know that the new tobacco strategy supports the Health and Wellbeing Board and the Health and Wellbeing Board's aim to tackle health inequalities. And actually, it's important to remember that tobacco is the new tobacco. What I mean by that is it still remains the #1 leading modifiable risk factor in regards to health inequalities. Hence the reason why we're prioritising this strategy and have brought it here tonight. Also, as you can see from the second point, the number of people that die. So it's important to remember that if there are 2 smokers, 1 will die directly as a result of smoking. So we had 191 people that died in Luton residents from smoking. And Chris Whitty quite famously said during the COVID pandemic that more people would have died during that period from smoking than of COVID. So we need to take it as seriously. Could I have the next slide, please? Everything we do in Luton is based around the Luton 2040 vision and eradicating poverty. Specifically here, you can see the number of people that are forced or pushed into poverty, specifically as a result of smoking. So I'd just like to take a moment to look at this in a little bit more detail, because what you can see here, particularly the second bar, is showing that some of our most vulnerable residents are pushed into poverty as a result of smoking costs. Smoking costs are phenomenally high due to the cost of tobacco products, yet we know this is fully avoidable, and we know that then that money can be used for better purposes for those individuals. Could I have the next slide, please? And then there's the wider impact on the Luton economy. So apologies, this is focusing quite a lot on finance, and I'm conscious we're at the Health and Wellbeing Board, but these things are intertwined. And actually, you can see here the cost per year to the Luton economy. And specifically, if you look at, for example, tobacco-related fires, over £1 million per year. Social care costs, again, over £3.5 million. The cost to the NHS, over £7 million. And then lost productivity, as you can see, they're the biggest cost to the town. So just shy of £60 million per year, completely avoidable if we were to progress with the tobacco strategy and being successful in delivering that. Next slide, please. So this what I've just outlined is the reason why that we're prioritising this work. Luton strategy, we had a strategy, I was involved in it back in 2015, got us to a point, but actually now post-pandemic, we've had to pick that up. We've prioritised that within the department as a piece of work that we were fortunate enough to have agreed by executive last week. And really you can see it's now a case of getting on with the work in hand. Part of the delay was caused by, we'd been promised for quite a while, a national tobacco strategy that's been infinitely delayed. And I think we've decided locally, let's get on with the job in hand. And obviously, if the tobacco strategy does ever see the light of day, we can refresh it in line with that. I've outlined the prevalence data. What we've done is map across the Tobacco-Free Luton Partnership, which I'll talk about more at the end, and reviewed the membership to get greater representation from a wide range of stakeholders. What we really know is that we can't deliver this by ourselves. We need to work in partnership, and we need partners to be brought into the vision and actually achieving the eradication of smoking, as we've described at the beginning. Can I have the next slide, please? So you can't have a strategy without having a vision. So the vision's there. I think from my perspective, what's more a focus is the targets. This is a topic area we're very lucky to have very robust, strong data on. So the absolute key target from a population perspective is to bring smoking prevalence down to 10% by 2028. And then we have underneath that more specific targets in relation to specific cohort groups. Next slide, please. And so in order to meet these targets, we need to prioritise what our approach is. And you can see here, I've talked about the importance of working in partnership, which is absolutely the number one priority that we have. Obviously, working to prevent the next generation of smokers. There's no point supporting a lot of adults to quit smoking if it's just being replenished by lots of young people starting to smoke. As I said, it continues to be important, and we're very lucky to have a robust smoking cessation service within the town, and that continues to be a cornerstone of what we're delivering. Communication remains as important as ever, and we're very lucky in Luton that we're working closely with our trading standards colleagues around tackling illegal products that we're very aware of. There's a wealth of illegal products within the town, and it's something that we as an area are not ignoring, and recognise that actually if we don't tackle that side of the problem, we're fighting a losing battle essentially. And then finally, as you can see, is around smoke-free environments and policies. Next slide, please. So these are, as you've seen in the report, some of the priority groups that we're targeting to start with. Again, it's a case of making sure that we have priorities, that we make a real impact before moving on, rather than just going with a broad brush approach. Next slide, please. So this is a 5-year strategy. In the first 2 years of the strategy, we've been able to secure a small amount of funding to do some of the activities that have been outlined here on the slide. These activities have been identified by the partnership, the Tobacco Free Luton Partnership, as key areas they feel that we should be focusing on within the first 2 years. Obviously, given the amount of money that it's costing the local economy, the impact it's having on health and well-being, relatively, this is a small amount of funding, but it's something to start with. So these are things that we're starting to develop in the first years of the strategy, but then we'll have to look again at how we fund the strategy in years 3 to 5. So next slide, please. As I mentioned there, we've got robust data around lots of indicators that are available, publicly available information, as well as the information that we get from the local Stop Smoking service. So those are some of the key performance indicators we'll be keeping an eye on to make sure that the progress is being made. And can I have the next slide, please? And then that aligns obviously in relation to the governance around, we have the quarterly Tobacco Free Luton meetings, but then that feeds and is accountable to the Health Inequalities Delivery Board. And we've committed to doing an annual review in relation to the KPIs that I've already shown before refreshing the strategy in 2028. And next slide, please. And that brings us to our conclusion. So as I say, we're here for the reasons outlined at the beginning, but fundamentally we welcome feedback. We welcome any comments, any suggestions, but also the most important thing is how partners can be involved in Tobacco Free Luton and ensuring we have the best and correct membership to take this agenda forward. And also I'd like to request from the board that they keep this in their minds, keep tobacco in your mind when you're working across a range of different themes like mental health or other areas. This is very much a cross-cutting theme. It touches on all of the core 20+5 themes that we have as well. So, we see this as a golden thread that can be aligned to all the initiatives that the Health and Wellbeing Board are doing. And as I said at the beginning, this is the number one modifiable risk factor in regards to health inequalities. So we really have to see this through and make sure that we get the job done. So I'll stop there and welcome any questions or comments. Thank you.
Thank you very much, Suleiman, and the team who put this together. And can I congratulate you on your presentation there, because you've got some really punchy lines that were slightly different and hooked me in. So thank you for that. I mean, that slide about the impact of smoking on poverty, that actually people didn't smoke, they would actually be out of the poverty. It's a different way of saying the same thing. So thank you for that. It's Phil, yes.
Hi, I attend the quarterly Tobacco Free Luton meetings. Back in 1950, vaping didn't exist. It does now. And I'm wondering, and in certainly the meetings that we've had with Tobacco Free Luton, vaping is a serious issue now on health and illegal products and the like. And I think one person mentioned that it's likely to be a major issue in the future. So I'm wondering, whereabouts do your numbers include, or don't they, the vaping issues?
Thanks, Phil. So these numbers don't include vaping in terms of smoking prevalence and tobacco prevalence. I think from our perspective, vaping is quite an interesting phenomenon. Essentially, what we say is that it's safer than smoking, but the preference is that you neither smoke nor vape. But we're very aware that this is the hot topic of the day, so that we can't ignore vaping as an issue. I think what we're keen to do, and Jerry's been supporting with, is some real clear messaging, because I think there's a lot of miscommunication and misunderstanding, and you're right, a lot of illegal products in relation to vaping. So trying to get a consistent, clear message around vaping is something that we're focusing some of that funding on. As part of the communication plan. I don't know, Jerry, if you've got anything more to add on that.
Yeah, just to add to that, like the message is clear that vaping is a means to quit smoking, not to start smoking. ASH, who are the Action on Smoking and Health group, they have just sent their policy recommendations to government this week, actually, in terms of more taxation on particularly disposable vapes, because these are the ones that are like colourful, they've got good flavours and they're cheap, and that's what the children are buying, and that is where the issue is coming in. I mean, as a parent, you'd rather your child be a vaper than a smoker, if you know. But what is potentially going to happen is there's going to be a whole generation of nicotine addicts. So in Luton, what we are doing is we're focusing our attention on sort of years 8 and 9 with an education campaign around vaping, around the harms of vaping, which is the nicotine addiction and the impact that can have on brain development. And then also putting together a toolkit for sort of parents, teachers and carers as well. A lot of people don't actually know the law around vaping as well, in terms of what is legal, in terms of the number of puffs in one of those bars, in terms of the level of nicotine in those bars. So giving people that information and also direction on where they can report like shops that are selling illegal or selling vapes to underage or selling illicit vapes. So we're going to be sort of focusing on those early years in the secondary schools with our campaign. Because we know that in Luton as well, that between years 8 and 10, that's when the number of pupils who have tried vaping actually doubles. So it goes from sort of 10 to 20% of people who've said they've tried a vape at least once or twice.
Yeah, I think the illegal vapes coming into the country where content of that material is unknown was a serious consideration. And there was a comment, correct me if I'm wrong, there was a comment at the last meeting or the one before, that one particular place in Luton had been raided 3 times and illegal vapes removed, but it was still operating. Why, when being raided 3 times, hasn't it been closed down, essentially?
I can respond to that. Yeah. So this is why I'm quite proud, actually, of Luton, because we're one of the only, as far as I'm aware, local authorities that are working in partnership with trading standards. So when we go to the regional meetings, no one's talking about illicit tobacco, illicit vapes or anything like that. But actually, because we're working and because it's being talked about at the meetings, we're working with Liz Bailey within environmental health, and as part of the funding is going towards paying for officers to undertake this work. I can't comment on why it's been raided 3 times and it's not been closed down. That's not within my knowledge. But it's something that we're very aware of and working very closely with Liz Bailey to use our powers as a local authority to do what we can in relation to this issue. And it's something we would like to do a lot more about. And I know that Liz and Serena are keen to bring a paper forward specifically around illicit products and the impact that's having on the town around organised crime and other wider issues as well. But that's to come.
Thank you. I can't see the name online, but one of the councillors got the hand up online. So do come in. Hi.
Hi, thank you. It's just Going back to, it's Councillor Tamina Saloon, by the way, it's going back to the vapes and shops. And there's been an explosion, and they're targeting these flavours at young people. They're targeting them at teenagers, and hence many youngsters are now vaping, and it's addictive. So it's a trap that's easily fallen into. So my question is there any intention to be more proactive around enforcement? Because I know for a fact that most shops are selling and not questioning the age of young people when they come in. It's not as well policed, if you like, as alcohol might be or tobacco is. So I just want to see and hear from you about the enforcement of vape shops selling to underage children, essentially. It seems to me, because I have teenage daughters, you can walk into any vape shop and just pick one up and you're not questioned. So, you know, what's the situation with that? And kind of waiting for people to report it when it's become normalised in a way. I don't think that's going to happen. We all know youngsters are vaping. How are we kind of tackling the sources of those vaping products? Thank you.
Go ahead. Sir.
Thank you. Yeah. So again, I think it's just to say that we are acutely aware of this issue in the town and the impact it's having on young people. And as you rightly say, the flavours, the way it's promoted, the cartoon characters and everything like this is something, you know, I personally find abhorrent. But what it is quite a complex issue in terms of enforcement and what our powers are at a local level in comparison to how these products are coming into the town, etc. It's quite complicated. As I say, it has links to organised crime. There's quite a wide-ranging issue. What I would suggest, with permission, Chair, is could bring a specific briefing note around this issue that's informed by the relevant professionals within that topic area. You know, I'm thinking of our trading standards colleagues specifically, because they understand this topic a lot better than I do. So with permission, I would suggest that we bring back an informed paper that outlines and answers some of these points that are being made.
I think that sounds a very good proposal. Yes, we're happy with that. So let's bring that forward. Thank you very much. And we'll give you time to pull that together. Thank you. Oh, yes, Nikki, go ahead.
Thank you so much. And I know we're all working together, but I just wanted to make some reference. In the paper you put subsequently about the CCG. So I just think, just for updating, it's the Integrated Care Board, we're all part of it. And you said about the tobacco dependency. So I just wanted to target in that there's very focused work, and it happens to be in the acute trust. So it's in the maternity and in inpatients. And that is, again, giving everyone a good start. So it's targeting some resources into those units. And that's only as good as all of us together. And equally, it is, and I know it has a slow start in the acute unit and it's competing pressures, but it is about emergency admissions. And we've now got, I think we've got a good programme. We've now got Faith Haslam, who is the new prevention lead, who's certainly given that an energised boost. And I did check with colleagues in mental health, and that's the other targeted. And you mentioned mental health, which is categorically. So it's only if we're doing end to end. And I'm exceptionally pleased to say that primary care, GP practices and community pharmacies. So we've got an end to end. So it's not about different people, different needs. And again, I know you're holding that line, but I just want to, because it looked a bit negative, and actually I think it's a bit more positive than that.
Yeah, thanks, Nikki. And actually, if I can take this opportunity to credit Faith, she, like you say, she's come in and given it a bit of oomph. So you're right, you're absolutely right. Hopefully we can get that into a position it needs to be. Thank you.
Thank you. I think a lot of the points have been covered. I was going to cover, but one of the things I'd question is the £100,000. I don't think we've got the capacity and trading standards that we need, because I think, thank you for the report, it's excellent. But how do we increase? I don't know whether we can look at a public health grant or whatever, or some other national lottery funding, because I think if we tackle this year, it has a knock-on effect on people's health. It has a knock-on LAD hospital. It has a knock-on mental health. You know, it's all related. Yeah, dementia, smoking is definitely evil, and the sooner we can help people come off it, you know, wean people off it. That's too. And I was going to mention about the vapes and shisha, the amount of, you know, how we can. We got the capacity to do it, because it's almost saying that we could have a dedicated officer go around, because we have a lot of shops And are we, and you're not going to be able to answer this, but one of the questions, thank you for asking that paper, because I was going to request anyway, that trading standards give us an overview of what they've done, because I think every 6 months we should see a report back that says we find so many people. I think that report needs to come here, so every 6 months we can see what progress has been, rather than just see how many people we've caught, how many shops we've prosecuted, and are we prosecuting the maximum fines? I don't know whether the fines are capped or if they're unlimited. I don't know. I think that'd be interesting to find out. But I definitely, my only concern would be that we've got enough capacity in trading standards, being that they also do a lot of other stuff, and maybe we need to do more around finding some budgets, targeted budgets for it. Thank you.
I couldn't agree more, to be honest. And I think we're fortunate because Liz Bailey is particularly passionate about this topic area. So the willing's there from both departments. You're absolutely right. It's about finding the resource to have a dedicated officer or if not more. So yeah, absolutely can bring that report forward. And then potentially one of the recommendations might be that, for example.
And I think, I think we should look at national lottery funding for something, because I think that's what it's there for. And I think it would definitely help. It's a win-win for all of Luton. It's a win-win for LD. It's a win for Luton if we can reduce the smoking. And I think one of the things in our shelter house is still smoke. Yeah, when you do secondhand smoke, that we also need to make sure that all employees, part of our goodness business charter, that's covered as well, because part of that good employees, they should be making sure that their employees not smoking from entrances, and other people having to breathe in stale smoke.
So can I? If this is in response to this one,
yeah, is that all right? Thank you. Yeah, I completely agree as well. More funding in this area would be great. I think up to this point, we've tried to be creative where we can on prioritising this. So additional funding that's come in, some of the work that Nikki was talking about is through specific inequalities funding, additional bits that have come in through public health. We're trying to kind of ensure we prioritise this as part of how it fits with other areas. So some of the impact of COVID, we've sort of thought about how this fits in. So we are being creative where we can with trying to prioritise this issue. But I think looking for other opportunities is a good idea, so we will take that away.
Bill?
I think it's just worth mentioning that the total wellbeing smoking cessation team have a pretty decent success rate, and the targeted lung health checks we did, the referrals from there that went through to the smoking cessation was quite reasonably successful. You're not going to get 100% by any stretch of the imagination, but I think they got close to 50% cessation.
Yeah, thank you.
So can I ask if it's possible to look at some of the outcome measures based on whether someone has been resident for more than 12 months or less than 12 months? And I know that's a big ask. But one of the big features of Luton is that we have a population turnover. I know in my practice we get a 30% turnover, so we might try and get 2 people to quit in a year, and a third one joins the practice, and so we've still got a higher prevalence. So there's something about knowing where your successes are, and that newcomers in to Luton cannot have been exposed to all the work we do. Is that possible to measure or not, even on some of the parameters that you're looking at, perhaps?
Yeah, I can definitely look into that. I think from what I know of the data, it's not possible as the data comes to us. But maybe if I could answer that in a slightly different way. So one thing we're extremely conscious of is within our Eastern European community, which is a newer community within the town, that they have much higher prevalence rates than other communities that have been here longer, potentially. So we can't quite do it as scientifically as you're explaining, but what we know from particularly a lot of London boroughs is they've had to approach that community differently. And, essentially we're starting that journey now. So we'll definitely look at the data, Nina, but I can't promise you it exists in that way. But we're acutely aware of our communities and actually not one size fits all. So we need to have targeted approaches for different communities, particularly newer communities within the town. And that's a piece of work we're working with the National Social Marketing Centre on specifically, to try and really get underneath that and make real progress within that community. So I think we're aware of different communities need different approaches. The data, unfortunately, the way it is, I mean, for example, all of that community would come under white other as an ethnic group. So it's really unhelpful the way that data comes through. So I don't want to promise something I can't deliver, but it's very much on our radar.
Thank you. Mark, we make this last.
Yeah, very much. I think just to remind everyone here, as we've spoken about, there is a limited amount of funding that's going into this, and actually what the team have managed to pull off so far is they've reached out and they've thought about this quite differently. So I think they deserve everyone's congratulations for that. If we are to target more and do more, then there could be an ask of more resources, money. So, you know, if that's a question, we can take that away and look at that, but that would be at the consequence of stopping something else. So that's the world we're in. I think I was going to pick up on Phil's point as well around vaping. This is a 5-year strategy. So it does feel like there is something maybe missing at the moment we want to think about and include really from that perspective. Again, ethnic breakdown, I think is really key. But as Suleiman said, actually some of the data isn't the best at the moment. But that's, again, something that we're looking at. And then the final point in the question for the team actually is, do you think we're doing enough work around what's the drivers for people smoking? Because actually, if you can stop and prevent earlier on, you know, that's something that's of real interest to us as well, isn't it? Thanks.
Yeah. So I think it is something we're not quite there yet. So we've had a legacy of being obsessed with 4-week quits. That's our background. That's where we've come from. Actually, the point you made is let's get back to doing proper public health, I would say, in terms of preventing young people from smoking. So the work Jerry specifically focused on around the young lungs. I've called it the wrong name now. Thanks for that, Mark.
Yeah, we're just to mention in primary schools, actually, we're looking at a campaign called Protecting Little Lungs, which is about like preventing like the visibility of smoking, particularly outside of school gates, with parents and carers that pick up and drop off time. So we're actually sort of reaching out to all the primary schools in Luton and running a competition for them to design their own smoke-free school gates branding. It's an activity that can either be run in class or as set as homework. We're encouraging primary schools to run it across all year groups within their school, and it's up to them to pick their own winner. And then that winner will get through to sort of a grand final, which we run across all the schools in Luton, either going to involve a judging panel or the public voting of the overall winner of the brand. And with that, we really sort of hope to sort of engage the children in terms of, you know, understanding like the harms of secondhand smoke and making smoking much less visible. So, you know, it's kind of a learnt behaviour a lot of the time that they see their parents doing it, that it's something that they think it's acceptable to do. So we're planning on starting at that sort of really young age with the primary schools in terms of that sort of education programme.
I did say that was the last one, but I'll give you one more.
I think just to echo on Mark's point, I think we understand, I recognise that this is a wonderful policy, but our concern is how we fund it, as Mark says here. Now, that's why I mentioned National Lottery, because I know we haven't got it, but the tragic thing would be to have such a wonderful strategy and we set these up without funding it properly and resourcing it properly. It's not going to be delivered. And I don't want to be sitting here a year thinking, well, hold on, we knew that. So maybe we can look at whatever we do. And I think to Mark's point, I think the strategy there, maybe we can look at National Lottery funding or something to give the team some resilience, because I think the win-win is for all of Luton, and a win-win for the hospital, win-win for the GPs, is win for all of Luton if we can reduce the prevalence of smoking.
Yes, absolutely indeed. So reiterate that thanks to the team, excellent piece of work so far, and we are behind you driving this on and alongside you as well. Thank you, and perhaps at a later point you can give us an update when you've got something new to highlight to us. Thank you.
That's great, thank you.
So we're going to move on now to item 8, which is the cancer outcomes and Mount Vernon Cancer Centre update. And I think, Nikki, you're starting.
Yes, I'm starting, and then I'll leave Jessamy to go through the Mount Vernon. So I'm going to assume you've had the opportunity to read the paper, and apologies from Kathy. She genuinely is sad not to be here, and this is her work with Jessamy's together. So the points to really raise, it's about, and it follows beautifully on from the dialogue we just had with Suleiman about improving prevention. So follows through, but most importantly, early diagnosis. If you've had a chance to look at the paper, you'll see that Luton in section 11, the demonstration that the early stage cancers in Luton are lower and the higher number of emergency presentations. So that gives you that figure. So really, it's the two issues are reaching the early cancer diagnosis ambition, which is clearly opposite to where we are at the moment. And again, it's reducing those inequalities and addressing that inequality, which again picks Mark's point. The paper sets out the key challenges. So I'm just going to read them just so we're really clear. Screening uptake is lower than average for bowel and cervical. Radiotherapy uptake is lower than other areas, which Jessamy will go through some, and we know the reasons why. A general sort of more less awareness of signs and symptoms of cancer about people presenting late. I don't think that's quite as clear, but I think again it's Mark's point about, you know, if you've got other competing pressures in your life, it may be the lesser of your problems at the moment. So it's not always it's straightforward. GP higher than cancer diagnosis rates. And I just want to emphasise that 5-year survival and the 1-year survival, for that matter. You know, the whole thing is significantly less. Now we know those, but what are we doing about it? So section 9 of the paper, I think, really eloquently explains there's a lot of good work taking place. But just to remind people, the Luton's Outcome Project, it's been sponsored by the Cancer Board. It's a multi-year programme. It's already been running for 18 months, and a number of those recommendations are short and they've taken place, and some of them are longer and will take, quite a few years to embed. If anybody wants that full report, Kathy said it's certainly welcome, and I know some colleagues here have. But it is all about looking at those longer term plans. Now, again, if anyone's got any queries from tonight, Kathy or it's James Ramsey co-lead all those projects, and there's work streams and primary care colleagues in Sally and Luton, the council, and other people in the ICB. So system level, there's absolutely joint leadership there. And again, David and Sally behind me should be, both cited and supportive of a number of projects if people have got questions. The Bedford Hospital Cancer Board, again, which David attends, seek those updates. I think for me, the other is that outcomes project, have been looking at some of those barriers, and there is a pilot scheme on transport, which Jessamy may talk a little bit more about. But I also just wanted to pick up some good work, because sometimes it all feels a bit negative. But working where I said about it's multi-agency, there's a pilot work taking place for case finding for prostate, and that's actually one of the primary care networks. So that's actually piloting it and finding a really effective way of working. And then if it's successful, we will literally scale that up with others. So there's audits taking place. And again, that's working with secondary care. And hopefully some of those early signs are suggesting that, again, it will mean a reduction of people presenting in emergency settings and taking up on that proactive in general practice. I think the only other one to mention, and again, it picks up a little bit with Suleiman of the cancer, is the community connectors. And again, just to jargonise things, again, it's a partnership working with Macmillan. It will have 3 years of funding. It's hosted by LBC, and again, part of that system approach. So I think section 9 of the paper, considerations for the Luton population, absolutely is about reaching into the community. It's about being very bespoke, because there's different issues for different communities, a different age group. So it is very targeted work. So very happy to hand over, and then we'll take some questions after.
Thank you, Nikki. My name's Jessica Kinghorn, and I work with NHS England. NHS England commission the cancer services at Mount Vernon Cancer Centre, which is the specialist non-surgical cancer centre for this population, along with the whole of Hertfordshire, parts of East Berkshire, Buckinghamshire and North West London, into actually North Central London as well. So it's a big patch. The old Luton CCG area makes up about 5% of Mount Vernon's patients. BLMK as a whole, it's about 11% of Mount Vernon's patients. So just to give you an idea of size. Obviously, patients tending Bedford Hospital don't all come to Mount Vernon. Some of those will go to Cambridge, Oxford or Northampton, which are the next places that they can go. Works out the last full financial year that I've got the data here for pre-pandemic, because things obviously changed a little bit during the pandemic, and we're just revisiting the data now for post-pandemic. It was about 600 patients a year, new patients a year for Luton, with about 8,500 events at Mount Vernon, which pretty much is 8,500 visits to the site. You may get 2 or more events in one session, but generally speaking, it's quite a lot of visits per person. The majority of those are for radiotherapy. So about 5,000 of that 8,500 are for radiotherapy, just to give you some context. So as I say, we commission the service, although, as you know, there's a plan to do joint commissioning for a number of specialised services from April through a joint commissioning committee with colleagues, which will involve BLMK, ICB. So we've been working very much in partnership all the way through. The review of Mount Vernon started about 2019 when some clinicians expressed quite serious concerns about the sustainability of the services, both from an estates and from a clinical perspective. From an estates perspective, the buildings was originally built as a tuberculosis hospital in 1904. It opened, and really are not fit for purpose for a cancer centre. The site is in Northwood in northwest London, and it's owned by Hillingdon Hospitals. The service is run by Eastern North Hearts Hospitals. So the clinical concerns were largely around the acute adjacencies. So not having the right specialties on the site to be able to do everything they needed to do. Cardiology being one example. So patients with heart conditions, we've actually had to restrict their access to Mount Vernon because there just aren't the facilities to care for them adequately. So we did this review. It was an independent clinical review. A team came in from other parts of the country and made 3 sets of recommendations. The first was some short-term improvements, which we did straight away, including more staffing and so on. And we're continuing to improve the staffing and make other improvements, particularly around estates. The sort of more medium-term one was that we should transfer the management to a specialist cancer provider rather than a DGH. So the plan, we went through a process. The plan is to transfer that to UCLH. And then there was a long-term recommendation that really the service couldn't continue on the site it was on. It needed to be located with an acute hospital. So we started a process to identify which site that should be. We looked at all the acute hospitals within the catchment area, including Luton and Bedford, and did analysis on distance and so on for the whole population. And it became quite apparent the only site that really fit the criteria, met the needs of the population, would be Watford. So we've been developing this proposal. A lot of patient engagement has gone into this, and UCLH put in an expression of interest for the capital to fund the development of the new hospital, to the new hospital programme, and we're still awaiting for the outcome of that process. As well as relocating to the new site, we were really keen that this wasn't just about fixing the estate and the clinical adjacencies and moving it from one site 5 miles from another, but actually we use this as an opportunity to improve health outcomes. And this is really where some of the first discussions around the Luton Outcomes project started, because when we started looking at the data, big screaming red lights around Luton in terms of why the outcome's particularly poor here. And that kicked off some really good discussions, some patient engagement. The community connectors idea has come out of that. It's been a really powerful process, and we are still doing work to try and better understand some of the challenges. So we're looking to conduct an audit at the moment around why patients, who is going ahead with radiotherapy and who is not, and the reasons why. So there's an audit of patient records that's going to take place very soon, to really help understand why decisions are being made, whether they are the patient's decision or whether the treatment isn't appropriate. What we have heard from patients is that distance is a factor, which wouldn't surprise anyone. It's not the only factor, but it is quite a significant one, not just in Luton, but in other places too. So as part of the relocation, we decided we wanted to make care closer to home as much as possible, so increasing the amount of chemotherapy that could be done at local hospitals rather than at the centre, building a new chemotherapy unit at Hillingdon Hospital. But importantly for this part of the patch, we want to build a networked radiotherapy unit. Which would mean that patients would not have to go to Watford, to the new centre at Watford for their radiotherapy. They'd be able to go to a centre that would either be in Luton or in Stevenage. And both hospitals have put in an expression of interest to us that they would like to be the host. And we're developing criteria with BLMK ICB and Herts and West Essex ICB to determine which of those sites to put the network radiotherapy unit on. This is all heavily caveated with, we still haven't heard about capital funding, which is a pretty crucial element to it. I'm just seeing if there's anything else in particular. I'm happy to take questions on it. We're looking at things like transport. If you mentioned transport, we're doing some work around transport to see how can we help patients from Luton get to Mount Vernon, both ahead of any relocation to the current site, but also then to Watford. We've done quite a lot of work with patients around understanding some of their transport concerns. We had quite a lot of themed workshops on different areas, transport being quite a popular one. So we got some really good ideas from patients, as well as some better understanding of some of the challenges that they face. So
thank you.
I think I'll stop there, as you can imagine.
Yes, let's take some comments. So this was a briefing paper for us. So comments or questions, Javed?
Thank you. So I'm looking at the network site either at Lister Hospital. Is there no possibility of doing both? Because obviously Luton serves a huge, because even Milton Keynes people come to Luton and hospital, and Bedfordshire BLMK is 400,000 people. And if we're going to improve and catch up on the cancer, because of the backlog of early cancer diagnosis, and if we suddenly see would we have the capacity to be able to provide the early help for people?
There isn't enough. There aren't enough patients to have two separate units, and clinically, it's not great to have two single linear accelerator units. So the plan would be to have two machines. Each machine can do about 8,500 sessions of radiotherapy a year. So the idea would be to have two of those on the same site, and the same team as the team at Watford operating them. So it would be a sort of split site team, as you were, overseen by UCLH. So when we looked at a three-site model, it didn't work in patient numbers or in safety terms. We're really confident that the network model with one network site in the north of the patch does work. We have the same issue with in East Berkshire. Again, they've got quite long journey times for radiotherapy as well, but there aren't the patient numbers to be able to fill a machine and provide a service. So at the moment, we don't have a plan to put one there either.
Obviously, being able to get it, are we taking into all the, whether it's public transport, whether it's by a bus, coach, train, because obviously trying to get over to Lister or Taverna can be difficult. I think, are we sort of modelled how easy it is or how difficult it is for people to be able to, when they do need the treatment, sadly, that they can easily get access it without them costing them a fortune in travelling costs?
Yeah, so when we've done the analysis, when we were looking at all of the sites to begin with, we did that by car and by public transport. And that was where Watford overall for the whole patch showed it was the best solution really for patients as a whole. Obviously that doesn't solve everyone's issue because it might be easier to get to Watford than to Northwood for patients from Luton, but it's still not really easy. So that's why we've continued looking at transport. Once we've got the capital funding, I think that will really motor much faster because we'll be able to start having some real conversations with people about what we can do. I think at the moment it's it is quite a difficult conversation to have because we don't know when this will be resolved at the moment. But yeah, it's definitely on our radar. We want to make it as easy and as cost effective really for people to get to their treatment as possible. We've been looking at all sorts of schemes, what they do in other countries and other parts of this country where they've got successful schemes in place, from volunteer schemes, taxi schemes, or there are all sorts of things. Building a direct train route or something probably isn't one of them, but we do want to try and make it as easy as we can.
So you're saying when we get capital. I have to say, as a GP in primary care with no estates funding, I think it's if. And so, it is in the middle air, isn't it? So it's what else do we do to help the outcomes of our population whilst we're waiting for these decisions that seem to be put off forever? I'm sorry to be so jaundiced on this, but it's the reality. How much, I have two questions for you really. How much have you engaged with primary care practitioners about the health and well-being of their patients that are in need of radiotherapy? Because there's the patient's view, but then there's the professional's view, and then there's the specialist's view. So that's one question. And is there any work anywhere in the country around really trying to optimise the general health of those who go onto a cancer pathway, who may then end up needing radiotherapy right at the beginning? Because areas like us around the country, the general health and nutrition of people in deprived areas when they start the pathway is not as good as, for example, wealthy Hertfordshire or whatever. So inevitably they'll have worse outcomes because they're not starting so well, irrespective of their multimorbidity. So is there any evidence from what people are doing elsewhere, or is there nobody looking at that?
I think the way that for this population in Luton that we've come at that is through the Luton Outcomes piece of work. We've had a look to see what else is happening, where's best practice happening elsewhere. And I have to say that the collaboration that there has been around the Luton Outcomes, I'm not convinced I've seen replicated from what I've seen. So whilst we are taking bits and pieces both from other cancer centres and also from other parts of the country, I think we're doing something very special here in Luton with people working together in a way that we'll start to see that. So whilst the Mount Vernon project is, I suppose the scope of the project is very much about re-providing the specialist end of the service, certainly for the Luton population, it's very much not being done in isolation. And it's very, very difficult because sometimes you can fall into the trap of if you commission this service just looking at this part of it. But I genuinely don't think that's what's happening here. I think this is really something quite different.
I'll just add that Kathy and James are leaning in under that fuller programme on the prevention, and that has definitely been one of the areas about wellness during treatment and after. So again, I can pick that up with Kathy and she can share a bit more. And that wasn't bespoke for Luton, that was, generally, because it has been identified exactly that.
Well, that's good to hear that they're leaning in. I'm not sure that my practice has had anybody who's contributed. So I think there's something about where are you getting to, but that's for a separate bit. Okay, Sally?
I was just going to add to that. so Chimeme in my team, who's obviously the lead for health inequalities and various other bits of work and community, is the lead for this work from my side, and the Cancer Community Connectors sit under her in her team. So from a public health perspective, we're very much linked in, and the tobacco work and the physical activity work and all of that is all very much connected. But I do think, I'm sure we could be doing more around that and thinking about it more. So welcome the thoughts, and maybe we can pick up outside around how we could do even more to connect that. So it's not just tobacco seen as a sort of thinking about inequalities and stopping smoking, but actually as part of that pathway, where can we link that in? So yeah, I can take that away and think a bit more.
Yeah, just on the GP involvement, it's something that we've been, because we've been developing the plan across such a big area. We have had GP involvement, but very, I suppose, little from different areas. I think the majority of the primary care involvement for this patch has been through the outcomes piece of work. However, I think it's very much on our radar as something to really go to town on, particularly as we're looking at the network radiotherapy debate and so on. Again, it's just picking that moment when we have got some certainty around the funding element. And I am being optimistic about the funding, because I think it's been well recognised both regionally and nationally that we have to resolve this issue, that things can't stay as they are. The site does need, does need that investment. I think how we do that is the tricky question. We have put in this year 7.5 million into the estate to try and shore it up a bit, and to do some developments. And there are possibilities, but if we can't get all the funding in one go, but we could maybe get it in stages, we might be able to do things like network radiotherapy early, so that actually people can benefit from a radiotherapy unit in the north of the patch before we've moved the main building. So we are looking at all the different ways that we can bring forward some of the benefits to the population in the north.
Okay, thank you. Sorry, yes, Mark.
Yeah, just a couple of quick. One's a question around data. So I started looking at the 28 target, and I just wondered if we had incremental targets up to that point to get to the 75%. But then I was drawn to, if you look at part 9, we talk about data from 2018. In part 11, we talk about data from 15 and 17, which feels helpful by way of giving us a bit of a sense, but not current in where we need to get to. So I think that's question one. A concern, I suppose, and just a point to put in the room is, post-COVID, are we worried about people's perception? Nikki made the point earlier about people being busy and being able to sort of be screened in the right way. Are we concerned coming out of COVID that's going to be more problematic with waiting lists and what we're seeing in the news? So is there something we'll be thinking about in that space? And then the third part for me was actually really interesting, part 10, and it'd be great to see some of that detail. But equally, what you have under part 10, some of them will overlap with the engagement, the screening, the signs and symptoms. So again, just have we done any thinking in that space?
I will take those back to Kathy, because that is exactly all those points is what she's raised, and that cancer board have got literally milestones along the way, so it's not just at the end. So happy to share that, and as I say, just that illustration of the cancer board reaching out into primary care, for example, that case finding for prostate, because we know that's a particular issue to the, I think it's the Caribbean population. So there is quite a lot of reach in, and Nina, it was Kamini Patel who was the lean in, and I know some of the primary care networks over the last year or so have received that, but can't do enough of it.
Sure. So we've got an update so far and a briefing. I think that's been really helpful to us, and obviously we'll want to know when there is some capital funding, and also when there's any networking, when there's some outreach, because that would make a difference to our population. And I think probably a further report from Kathy at intervals, really, on the progress they're making, because this is such a big area of importance to our population.
And just to follow up again, on that, the data is quite out of date, isn't it? I mean, that must be problematic with charting whether we're going in the right direction or wrong direction. Sorry to come back. I just thought that was quite important.
The data. The data is from different sources. So, for example, the Cancer Alliance data, it was the latest Cancer Alliance data there was. But I can take that back certainly from the data that we've been looking at Mount Vernon. We are trying to refresh everything. The census data that we use for our equality impact assessment was 10 years out of date, but we've had to wait until very recently to get our hands on the latest. So we are refreshing it when we get the more up-to-date data.
There is always a lag on cancer data because it has to go to the registry and get cleaned and all of that. So cancer data from the national perspective is always quite far behind. Yeah, that is quite far behind.
On here, I know that you said you don't know when, but because it says here, a decision has not been announced by the new hospital programme and capital funding. Does that mean that you're waiting for a decision, or do you know, is there a time frame of when you'd get a decision on that? It just seemed as if you were waiting for something and it wasn't announced while you're writing this paper. So are you waiting for?
Yeah, we are waiting for a decision. We don't know when to expect it. The original timetable passed, so we are waiting for news. Now, that doesn't mean we're not doing anything though. We're trying to make sure we're in a really good state to go ahead when we do get the funding, either through the new hospital programme or once they've made a decision. If we're not on the list of hospitals, we can then start to pursue other routes. But we're doing some background work, we're talking with the national team, and we're looking at what we can develop in advance without needing the capital. So, for example, chemotherapy at home. One of the clinicians has developed a proposal and done a pilot on chemotherapy at home, which should reduce quite dramatically the length of journey times for patients attending Mount Vernon for chemotherapy. And whilst that's quite a small amount for Luton, there are 4 new cancer drugs or chemotherapy drugs about to come on stream, which will have a significant impact on the number of patients that are having chemotherapy at Mount Vernon. So if we can have some of those treated at home, that will save travelling time for patients.
You're saying there's a low number of people uptake or accessing chemotherapy. Do you have data around people that aren't actually accessing it because of the distance and travel, etc.? Do you have that data?
Not for chemotherapy, because chemotherapy, we've got a really good, Luton Dunstable Hospital has got a chemotherapy suite, and they're actually the only hospital in the Mount Vernon patch that does immunotherapy as well. So it does more advanced form of the SAC, what we call the SAC, so the chemotherapy type treatments, than any of the other hospitals in the patch. So more Luton patients can be treated at Luton Dunstable for chemotherapy. We've got a Mount Vernon team that come into Luton Dunstable. We can't do that for radiotherapy, which is why the radiotherapy number is much bigger. And it's radiotherapy where we think the uptake is really low, and it's much lower for Luton than it is for other areas.
Just recently, I had somebody on my street that refused to go anywhere because she wasn't able to get out because of family and children, or anybody to support her to go to get any treatment. So she got no treatment and refused to see anybody and stayed at home. And we only found out that she passed away with cancer later on. So that's just one case that I know, literally on my doorstep, just a couple of doors down from me, nobody even knowing, because when I asked her husband, she said there was no one to look after the children and she needed a husband to be with her, and she refused to have any treatment.
And that doesn't need that's the sort of the relational stuff, isn't it? It doesn't need 4 walls. It needs relational understanding and being open about that, and then trying to find some solutions, which maybe the community connectors might be able to work on.
And I think what the sad thing was that she'd gone away abroad and had been diagnosed abroad, but when she came back with her results, the team here took ages just to even go through results that she already had to say that she had cancer. And she'd just gone for a routine checkup abroad and she'd come back with it. And then this is why she was just, there was nobody there to support her to be able to, it took such a long time through the GPs that she just refused to have anything and said, I need my husband, my family around me, and I'm not going to go anywhere. So it's really, really sad just to hear that there was people out there that you know. I mean, I didn't know. I was only a couple of doors down. So it's just sad stories that this is something that it's a real story that I've really seen. So it's a shame, really, that we don't know how many more people we'd have like that aren't going to go outside to get the help because they want their family to be with there, and it's not accessible for them because it's far away.
So one thing that would be helpful if we get examples like this, which have tragically ended the wrong way, would be to actually do a quality improvement case review and look at what the learning is. And I know that James Ramsey and I work on some other things together, and he's very keen on doing these case reviews to get the learning, because actually it's only by going into depth that we can go far enough back to understand where things might have been done differently and therefore put something in place for someone else. So I think that is something that perhaps we should recommend into the cancer network, that they do some case reviews on where things have not gone well, if someone will agree for that, and then we can see where the holes are, and then what difference can happen. Last comment, because we've got a lot of the rest of the agenda to deal with.
Sorry, yes. So I think the audit that we're doing will really help with that. That's a deep dive into all the patient records. That's radiotherapy specific. And I think every patient at Mount Vernon, so once you've got to that stage, who is then transferred because there aren't the clinical facilities available, each one of those is reviewed. So I think it's looking at the other end of it, really, and who doesn't get there in the first place that might need to. But we can pick that up with James and Kathy and have a chat about how we might come at that.
Thank you. I will move us on now, and thank you very much for some really good comments and debate, and thank you for the paper. So our next item is the Sexual Health Needs Assessment, which I think is Michelle to present. Is that right? Michelle, you're on the line.
That is me, yeah,
you.
I'm on the line. Yeah, I won't go through it. I presented it as a slide deck, so you can see the data, you can see it a bit more visually. So I'll just pick out some of the high level points. So just as a word, we started the Sexual Health Needs Assessment 21-22 primarily because we were needing to recommission our sexual health services, which we did at the end of last year. So the needs assessment was to inform that recommissioning and to feed into our sexual health strategy and HIV action plan, which we'll be developing this year. So some of the data has had a bit of an impact from the pandemic and needs sort of updating. So just on kind of the first couple of slides, you can see the impact of the pandemic, where in 2021 we had reduced attendances, but we did have a massive increase on online activity, and pleased to say that that's continued. You can also see that there was a bit of a reduction in our out of area attendances, so that's residents from Central Beds, Bedford and sort of Hertfordshire predominantly using our services, but that has picked up again. So the members need to be aware that kind of our sexual health services are kind of open access, so it doesn't really matter where you live, you can access any services anywhere in the country, and then there's sort of cross-charging arrangements behind that. It wouldn't probably surprise you to see that kind of when we've looked at gender, we have more women attending, but that's because our sexual health services also provide contraception. So we have quite a good uptake of LARC, which is long-acting reversible contraception. So that's kind of coils and IUDs, implants and injections. This data is just what is delivered in our sexual health clinic. The data later on around kind of LARC is across the town, so which is so contraception delivered by our GP as well. And then the highest age brackets between 20 and age 50, but increasingly a bigger uptake of our 16 to 19-year-olds, and which you could see in 2020 kind of had increased. And throughout the pandemic, that under 18s and specifically under 16s were prioritised, so they would still be being seen face to face. There's a little bit of information around kind of ethnicity. Highest population attendance is white British, and so it's not really representative of our population, but we are making inroads of kind of how we do that and how we kind of reach out and go to provide more outreach and go to areas so everyone can access that. And then postcodes, and we've looked at where people live. Highest is kind of LU1, LU2, but the clinic's based in LU1, but we were seeing an increase in kind of the other areas. So just as an aside, initially when we had the sexual health contract, it was meant to be a hub and spoke model. That didn't really work, so we had staff just sort of sitting in kind of GP surgeries or pharmacies, but we've moved to a hub and outreach model, and with working more closely with our pharmacies and our GPs to kind of deliver sexual health services kind of in their own right. The HIV, Luton's always had a high prevalence of HIV, and compared to kind of the east of England, but there has been some different sort of commissioning that we've had to do over the last couple of years. So something called like PrEP, which is pre-exposure prophylaxis, can't speak today, which is a new drug that was commissioned, I think, the end of 2021, which is delivered by our sexual health services now, and that's a preventative drug, so people can take that, and that stops them contracting HIV. The uptake of that, I don't have the data to share. That wasn't part of the needs assessment, but I can always bring that back. But that the uptake of that is has been really good in Luton, so hopefully that will have an impact on our HIV rates, but that will probably be longer term that we'll see the impact of that. And then there's a national piece of work which is around kind of reducing our transmissions to 0 by 2030. So that will be one of the key areas in our sexual health strategy and our HIV action plan. As well as having a high prevalence of HIV, we have a high rates of late diagnosis. So that's people that are diagnosed kind of later on, and although they can access treatment, it does impact on their kind of morbidity, and also it doesn't help with the transmission. So the earlier that you can treat HIV, people have a better chance of living better lives, and also if their CD4 count is low, they can stay on treatment, and then they won't be able to pass it on. So it's something like it's sort of undetectable, untransmittable is the phrase.
So Michelle, on the we've got a slide with your key recommendations.
Yep. Go to the end.
So is that you're seeking Health and Wellbeing Board to comment on those recommendations, and I think we are asked to approve this strategy. Is that right?
It was just to update the needs assessment and any sort of comments, so and approve it. But if you need me to come back with more up to date information, some of the data I can do. So that we could do that as part of probably come back with the sexual health strategy when that's written and developed. So that might be a better way.
Okay, thank you. So can I ask colleagues, have we got any comments on the information we've received tonight? Thank you. Well, some of the issues, a bit like Suleiman said before, we've been around this before, as in we have a high rate of HIV and a higher rate of late diagnosis, but I can remember it being higher than this. So I think we're moving in the right direction, and also like the teenage pregnancy rate as well. We've moved well in the right direction. So there's some good progress on the work that's been undertaken. There's obviously always more to do. And you've got 4 key recommendations, one around HIV, the sexually transmitted infections, pregnancy contraception and termination for the under 18s, and supporting vulnerable at-risk groups there, which helps us to target and focus. And are there any targets for that, that we've got any data to hang on to that? Or just that these are the focused areas with not necessarily...
So they were the focused areas that then fed into our recent recommissioning of the sexual health service. That's what we based our sort of specification on. And then they will have certain KPIs linked to those. So which we will obviously performance manage on.
Thank you.
We could
Sally,
set
did you want
targets.
to comment?
Thank you. Thanks, Michelle. I was just going to come in. The reason why this has come as just the needs assessment and showing the data was it was from a conversation at a Health and Wellbeing Board months ago now, that's just saying that this had been done, and it'd be really interesting to have it as a discussion point here just to see where what the data is showing and the direction of travel for the population in Luton. But I just wanted to make a point on the HIV late diagnosis and identification in Luton, the prevalence in Luton, because we have recommissioned the service, but we've incorporated HIV now within that integrated service. It used to be a separate item. And within that, we're really wanting to focus on this particularly and really make even further inroads on it. So, as you said, lots of good work has happened, but it has lost its focus a little bit through the last couple of year and a half, couple of years. So this is an opportunity now to really drive it forward again and have some really good impact on that area. So we're really keen that we have that action plan and move it forwards now.
Thank you. And again, from personal experience, the influx of people from Eastern Europe, there are a number that are then diagnosed with HIV. So I think it's about focusing on groups that we know are moving in the population, as well as other demographic groups.
And that demographic around HIV has really shifted and changed over the about 20 years that we've had it within our population as a priority.
Yeah, and I would just say as well, Nina, you mentioned the sort of a transient population that we have, but also the refugees that we have in the town. So we've had quite a few cases of those people in some of the contingency hotels or overnight hotels that are being diagnosed with HIV. But locally, and when we've been sort of monitoring it in the last year or so, we're seeing less and less people being diagnosed late, which is good. So they're being picked up earlier, perhaps at their GP surgeries or maternity, but they're not necessarily from the populations that previously that we would have thought they were from. Yeah.
Yes, thank you. And that's about how we approached it. So I know that there's a lot of work with homeless and the asylum seekers. Everyone gets screened. It's normalising it, isn't it, really?
Yeah.
Okay, so thank you. We've got the needs assessment here. We've brought to the Health and Wellbeing Board. Any other comments from anyone? And we will thank you for progress on that. Okay, so moving on to Better Care Fund, and I think that is Kate online.
Good evening, everyone. I'm Kate Sutherland. I'm Integration Manager for LBC and ICB in a joint role across the system. And my role tends to cover all the enablers of integration, which includes the Better Care Fund. And the report you've got tonight in front of you is actually the Better Care Fund annual report. This lands with you every year. About this time of year, the Department of Health and Social Care lets us know what sort of money is coming forward to Luton, and we start to do our planning around it. Joint Strategic Commissioning Group have approved the allocations that have been set out in the report today. And what I'm looking for from members is to give them oversight on what we've allocated to, and also to have approval in order to go forward with the plan. So the past 3 years, you may recall that we have allocated 97% of the budget from the Better Care Fund to core services. And the same sadly applies this year. In order to support core services in the way that we need to, there's only 3% that's going forward to change schemes. The total of the fund is 26 million, and 17 million of that is allocated to the BCF fund. 96%, as I said, is going to core services. Those core services do cover integration, so they are meeting the criteria. They're for joint contracts, joint roles, and for pathway support to specific services to ensure that we have the flow and the integration across the pathways. IBCF, once again, this year has also been allocated in totality to adult social care to support the adult social care budget. So there are no change schemes in IBCF. But the three change schemes that do sit within the Better Care Fund are continuations of last year's change schemes, which are the Enhanced Health and Care Homes, which is implementing the framework to support care homes and access to the NHS, and the New Falls scheme. So the New Falls scheme we were hoping to be able to set up last year. It includes a single point of access and a therapy model of care. Now this will create an equitable pathway across BLMK. They're the two items that were missing from the Falls pathway in Luton. Unfortunately, they did have trouble recruiting to some of the roles that were required for the SPA. So this is carrying over into 23-24 as well. And then the third scheme is Ageing Well scheme, and this is about physical activity in the over 65s who have a mild frailty score. And it's to improve the balance and mobility of that specific cohort in partnership with Be Active across Luton. So those are the three change schemes that we've actually allocated. As I said, 97% of it is going to core funding, and we're looking for approval for that to go forward for its third year from members.
Thank you, Kate. That's very clear. Core services, the three change programmes with very clear outlines of what and why. And good to have the additional gaps filled for the Luton on the Falls pathway. So thank you. So any comments or questions? Are we happy to approve? Yes. Seeing some nods. Yep. Okay. Thank you. So thanks very much, Kate. Approved. Moving on then to the draft Luton Population Wellbeing Strategy. Sally, that's you.
It is indeed, thank you. I've got a presentation. That's just disappeared at the wrong moment.
Your laptop is actually
okay.
So should we, or do you want us to do the social discharge fund first and then come back to the presentation?
Yes, that would be good.
Yeah, so let's move
Kate as
move
well,
on.
actually.
So Mark, are you able to? Sorry, beg your pardon. It's Kate, isn't it, about the hospital discharge fund? Yeah.
Thank you. So most of you will be aware that a new fund has come forward to the Better Care Fund. It was issued in December, and it's the Adult Social Care Hospital Discharge Fund. Its rationale is to support winter pressures and enable discharge from the acute into the community and hopefully back home to their usual place of residence. This particular fund has to sit within BCF, and it also has to sit within Section 75. So with partners, we've allocated the fund where we thought we could create the most impact on discharge. And within the report, you've got a breakdown of where those areas are. In brief, this is a short-term fund. It has to be spent by the end of the year. It can't be carried over. So we've allocated into areas where we feel we can spend that fund as well as create that impact. So it's 1.7 million in total. And if you look at the report, we have a few areas where we're already seeing an impact happening. So we've increased the hours of reablement, which is absolutely critical to getting people out of the hospital. We've also increased the capacity within dom care. We've set up an interim service, which is a dementia intensive support service. This was a gap that was found to be in Luton. It's a partial reflection of the Bedford service, but just a partial reflection because of the time frame that we have to be able to set that up. This particular service supports people who have been discharged with a dementia diagnosis into care homes, and it supports care homes in training and settling in that patient and the ongoing support. We're hoping that this particular service will go forward into the new year if they can find funding. There's a business case pending to actually increase that service to the level that Bedford have. As well as that, we've spot purchased intermediate care beds and Destiny mental health beds to increase the capacity within the community, and those are being used to the maximum capacity. We've also provided additional transport, and that is not to increase discharge, but it's to ensure that the discharge is actually timely coming out of the hospital. So those are the core allocations that we've given the monies to. Going forward, the grant does end on March the 31st. So obviously some of these services will come to a halt at that point in time, but though we're already seeing the impact on discharge, so we're hoping that we will be able to step down most of the services. It has been announced that there's 600 million coming forward in 23-24. As to when that money comes forward and what Luton's allocation is, we don't have a picture of yet. We are hoping that it will be annual funding rather than winter pressure funding, because as most of you will be aware, there hasn't been the drop that we normally get throughout the rest of the year outside of winter. But as soon as I've got information on that, I'll make sure that members are informed when that money is coming forward. So to support this fund and the allocations we've made, we've had to make an adjustment to the Luton Section 75 agreement. And so therefore, there has been a deed of variation circulated to members, which we do need approval to go forward to legal due process in order to add it to the Section 75 agreement for 22-23. Are there any questions on the allocations that we've made or anything else that I can expand on?
Javed? Yep.
So I only have one question. Is an additional sum has been assigned to NOAA to support discharge where there is no risk of homeless. Obviously, there's others as well. Did we pick NOAA? But obviously, I know in Luton we've got more. How did we come to that conclusion to pick NOAA? Did we go through a process?
So we were looking for bids within the voluntary and community sector. There are three charities that have actually been given money through the fund. One of them is NOAA, because we did want to address homelessness in Luton and the difficulties that we have in discharge. And that was a particular crisis that was happening in the hospital. So they stepped up for that particular ask. But we have also allocated to Red Cross and Age Concern, and that is to support people in preparation, preparing the house, preparing the shopping, settling people in when they're discharged as well. So there are three allocations to the voluntary and community sector, but NOAA are the sole ones around homelessness, and they were the ones who came up with the bid.
Thank you, Kate. So I think we can approve, yes, the allocations and the memorandum that's been put before us. I suppose I would ask that we learn what's worked, so we evaluate what's worked well, what was difficult, so that we know what we would try to do next time. And if something's worked really well, can we make it business as usual?
Yes. Well, we're reporting fortnightly on the fund, Chair. So there is a fortnightly report going over to the Department of Health and Social Care. And I'm happy to feed back on those reports as well, if that would be of interest to the members. So far, the outlook is good.
Thank you. I've just been reminded that actually we did approve this online, so this is ratification in a public meeting. So thank you. That's clear and documented correctly. Thank you very much, Kate.
Thank you.
Okay, so let's step back now then to Sally and the wellbeing strategy.
Thank you. So I have got a presentation. In the papers, there is a long version of the strategy, which I know is very long, but important to capture all of the information in there somewhere. And then there's a shorter version, and then I've just done a presentation to sort of pull it all together. This is draft. So it's very much about getting feedback and input into this strategy. And this is the health and wellbeing strategy. So the statutory strategy that sits under the Health and Wellbeing Board. It's a partnership strategy. For us, we're calling it the Population Wellbeing Strategy. So it's a key strategy as part of our 2040 ambitions. So it covers a lot, hence it's quite large, but it's really important. So it's a really important strategy for us in Luton and how we move things forward across all of our work. So the slide deck is just the sort of headlines around what the strategy is about. So on to the next slide, please. And I've been working with a designer to start making some of the visuals into the 2040 branding. So the slide deck has some of the new bits in there. So this slide just summarises where it fits in amongst the 2040 strategy. So I've just put a little star on the themes that are very much aligned to this strategy. So the key one is around, obviously, that pink one around improving population wellbeing, but also has a really strong read across to the child-friendly town agenda and the fairness work and the fairness task force. Just going to get mine on my screen as well so I can actually read. So the next slide, there's a lot of data in the long version that outlines some of the where are we now and what do we want to achieve, but I've just pulled out the really key headlines for this slide. So this is about health inequalities in Luton. So we know that we do see a lot of health inequalities in Luton, that we are a borough with quite high levels of deprivation, particularly in certain areas of the borough, as shown in the map there. So red is the more deprived areas. And we know that has an impact on life expectancy and various other health conditions that are more prevalent in those that are more deprived. There's also not just the health conditions, but the social determinants of health around cost of living, employment, housing, education, that all impact on health and wellbeing. And again, lots more detail in the longer version, but some key points in this slide. And then we know that we were hit quite hard in Luton through COVID pandemic. So that map there in the middle shows the wards that had the highest number of cases during the pandemic, and it tended to show the same pattern as our deprivation maps around those wards that had higher cases of COVID. At one point during the pandemic, we had the highest case rate nationally, and we were always known to have enduring transmission, which meant it was a sort of national term that meant that we had higher prevalence, and the prevalence stayed higher for longer. And I'm sure you all remember the many reports that were brought here around what our position was in COVID, and at points it was really quite an awful position that we were in Luton. So we need to build on that learning and build back from that. But also just really think about the impact that has on health inequalities and continues to have on health inequalities. So those areas that were harder hit by COVID, again, tended to be the more deprived, the people that had to go into work because they had cash in hand jobs or that kind of type of employment. So the sort of multiple factors that then layer upon layer around inequalities is really important that we don't forget as part of this strategy. And I'm also really keen that we continue to build on our experiences and learning during COVID. So just in that pink box there, just some 4 key elements that I don't want to lose through the implementation of this strategy. So that understanding of inequalities, that understanding the community voice and working with the community to build change that we really did well during the pandemic, system working across healthcare, voluntary sector businesses and other partners, and using the evidence base and local knowledge to drive action. So those are things that we did really well during the pandemic and want to really carry through this work. Next slide, please. So there's, as I said, lots of data in the strategy, and this slide just summarises the key bits throughout all of that across the life course that we want to make sure we focus on during this strategy. So you probably, hopefully you can read that on the big version. But I'll just whiz through a couple of the key ones. So we have a comparatively high rate of low birth weight babies. Our childhood immunisation rates are lower than national average, higher obesity rates than national average. And I appreciate this is very sort of highlighting the negative, but these are the bits that we want to focus on. So hence it may come across as a bit negative, but where we have the challenges that we really want this strategy to deliver against. So we have high rates of hospital admissions for substance misuse in children and young people and rising. More disadvantaged students as measured by free school meal eligibility, although those with free school meal eligibility do perform well in schools comparatively. And we do have children that are, young people, 16 to 17-year-olds that are not in education, employment or training. It's better than the national average, but there's still work to be done. We have lots of other areas across the life course where we want to focus. We've heard about the HIV late diagnosis, which is a particular challenge. Salary rates could be higher compared to people that don't live in Luton, that work in Luton but don't live in Luton. We have relatively high crime rates, higher than average obesity and lower rates of physical activity, high levels of smoking, as we've heard this evening, and alcohol-related hospital admissions. And then in the older age groups, we have higher than average rates of under 75 mortality for both cancer and CVD. We've heard already this evening about our poor cancer outcomes in Luton comparatively and our lower than average cancer screening rates. So those are just some of the highlights. I'm not going to go through all of them because it will get a bit tedious, but those are some of the areas that we really want to focus on through this strategy. Next slide, please. So this is just a bit of our story around becoming a Marmot town. So we know that health inequalities, as I've mentioned, is really important in Luton and has been exacerbated through COVID. And this has largely led to us working with Sir Michael Marmot's team and the Institute of Health Equity around what we need to do to really tackle health inequality, health equity in Luton. And are on the journey to become a Marmot town, or we are a Marmot town, but are on the journey around implementing the actions and what that looks like to really have an impact in some of these areas. So that just lays out the story, and there's more in the longer version of the strategy. Next slide. So this is our overarching vision and priorities across the life course. So across the life course, and this relates to everything I've just mentioned, but then also the 3 sub-boards that we have for the Health and Wellbeing Board that we have in Luton. So Start Well is largely delivered through the Children's Trust Board. Live Well is largely delivered through the Health Inequalities Board, and Age Well largely delivered through the Place Board, but obviously there are lots of overlaps there. So it's not just Age Well at Place Board, for example, and Live Well in the Health Inequalities Board. But over those life course areas, we have at the top of this visual the systems approaches that we want to be doing collaboratively, working together to tackle some of these issues. So child-friendly Luton, family hubs approach that we've got in for children and young people, and then some of the linked work programmes around safeguarding. And then for Live Well, we're talking about becoming a Marmot town, thinking about community hubs and community connectors approach. And then in the Ageing Well section, we're talking about health and care integration and resilience of the health and care system, care in the community and neighbourhood teams, digital transformation, so some of the digital offer in care homes, for example, and then population health management as an approach to better understand data. And then in each of those life course, we've got some key priority topic areas that we're wanting to focus on, built on the evidence of where we need to tackle and do more work. So I'm not going to go through the next slides in detail, but the next slides then just show, if you go on to the next slide, some of the, under each of those headings, what do we actually want to achieve, and how, and what are we actually going to do. So there's quite a few slides there. If you could just click through them all I'll tell you when to stop. Keep going. So that just shows, that one. So this just lays out across the 5 years that we're proposing this strategy runs for the key headline actions, so very high level, but that we want to be delivering upon. And again, it is in the short version that's in the pack. And then the next slide just shows how we are going to deliver this and the key framework that we will have for measuring, but not the actual indicators. And I intend to bring that back in the April Health and Wellbeing Board. So it's delivered, overseen by the Health and Wellbeing Board, and then the 3 sub-boards, as I mentioned, will be the key sort of workhorses and drivers of the strategy. with task forces, working groups underneath those as needed. And we will have a framework for measuring the impact, which will sit with the 2040 indicators, and then for each of those boards have some high-level indicators to show direction of travel and some more detailed dashboards for each of those topics that I mentioned as the priorities. So mental health, for example, SEND, CBD, etc., so that we can draw down into more detail across those. And then the last slide is just a proposal for how this comes back through Health and Wellbeing Board. So up until this point, as part of the delivery of the Health and Wellbeing strategy that we had previously, we had updates from each of the three boards, and they were more around what did we talk about in the last meeting, what did we pick up, and I'm just proposing as a discussion point that instead of that way of doing it where we have activity updates from the three sub-boards, we have key big ticket item sort of topic updates. So this is only me just thinking through what's coming through, but is up for discussion around a work plan, but have key big things that come through as they're being shaped into this board for discussion and helping to direct the way of working and direction travel. So, for example, for the next meeting, we could have an update on the family hubs approach. Marmot Town delivery and evaluation plans is coming anyway on the forward plan, but that's a key delivery way of working for the strategy. The Fuller Teams update and how we will measure the strategy. I also want to come through to the next meeting, but then going forward, we would have some other big items that are being shaped and delivered through the strategy, such as the mental health strategy, the food strategy, frailty and complexity, winter planning, various other bits, Marmot 1 year on. So things that are really big that we can help shape through this board. I'll stop there. Thank you.
Thank you. I think the idea of chunking up the focus within this board in this way is a good idea, actually. So rather than thinking of reports from boards, it's about what are the pieces of the strategy that we're working on, and what do we need to know, and what do we need to make changes to. So I personally like that idea. I'm seeing nods from elsewhere. So that was my comment. Any other comments or questions for Sally? We're all tired, I think.
I know. I can't believe there are no questions.
There's a lot of work in this, and it's formatted very different, well, quite differently from previous iterations. So there's a lot of work gone on in the background, so thank you for that. Yeah, Mark.
I think the way Sally's broken it down from the long report to the slide deck that was in there to what we've seen tonight is really helpful. It'd be good. I haven't seen that myself, I don't think, so I might have. Yeah, I was thinking, have I seen that? I'm sure I heard Natalie when that's like. So I think it'd be really helpful if we could circulate that to everyone. And then if we've got any comments coming back from that, as Sally says, this is so important as a key point of structure for us in 2040 and what we're doing. And actually all of the other groups we're talking about, it is bringing things together in a meaningful way and actually feel part of the problem solving as well. Hence, and I agree with you, Nina, I think that last part's a really good way to do it.
And I think there's something about we might, I realise you've put some things down on a chart and pulled them out, not pulled them out of the air, but they've gone up at certain places on the chart. So we might look at it and actually have a view that there are certain pieces of work that need to be earlier rather than later. So I think, look at the timeline and make some suggestions. What are the key enablers and then what are the follow-ons? So certainly welcome that. And yes, certainly welcome the sharing of the slides and responses to that, which should then inform the work programme going forward. So yes, thank you for that.
Yeah, absolutely. I can share the slides, and as you said, that table at the end with the forward plan for the meetings, it was just sort of finger in the wind, but needs a bit more thinking around what actually is the timeline of all those big items. But yeah, as an approach, thank you.
I think yes, we like the approach. Thank you for the work. Anything else? When does this need to? If this gets sent round, does it need to come back again for a final approval, or? what's the intent? Because it says strategy draft again.
Yeah.
So when are we going to do the this is it, and we're going to sign it off?
So now that it's come here, it will need to come back again once it's gone out and gone around a bit more. But this was obviously it was supposed to come before Christmas and be sort of a bit further along by this point, but it will need to go. I'd need to check whether it needs to go to consultation actually, but it will need to go to other places and then go to policy and exec, but it will come back here again as well.
So Bertie's saying 6 months?
Probably, yeah.
Yeah, okay. So I think we have one more Health and Wellbeing Board in this administration, which was the terminology I was given by Hazel, so in April. So it would not be ready for that? Not.
I'll need to double check on timelines and
okay,
things possibly.
Okay. Right, thank you. So if there's no more comments on the draft strategy, then let we complete our work for this evening. So we've got the work programme as next item, which, bearing in mind that this is as we see it now, and it may be that we choose to have something slightly different further forward. Is there anything that would like to be brought to attention for the draft work programme, which we're asked to approve? So anything, Bert, that you want to raise, or anything from any of the officers that they want to see different? At the moment, we've got the April meeting would be, yes, it's 5th of April. That would be Marmot Town update, public health report, which is a standing item, public health intelligence. So are we happy to approve that? So yes, Nikki?
If you would like, as the link director, the ICB, very happy to bring an update ICB report. And I'll check with, obviously, with Robin and Sally. So just bring the salient points for yourselves.
Probably put it on the last one of the administration would be very timely, wouldn't it, really? Yes, the next report. Yep. Okay, thank you. Otherwise, we approve. So that is the end of our meeting. As I say, there is one more meeting in April before the end of the administration, and Maud will be retiring, I think, the day after the board meeting. So she may or may not make the next Health and Wellbeing Board, and that's entirely her choice. So, Maud, I'd like to say thank you very much for all your work here in Luton, and we wish you well for your future. We had a little chat earlier on, and it's a very different future with lots of choices and not so many emails. So well done, and thank you very much for all the work you've done. And we want to note that from the Health and Wellbeing Board. Thank you. And if there's no other business for anyone, I think we can all go home. Thank you.